This manual will show how to proceed the central vein catheterization, jugular vein. An internal jugular central venous catheter, CVC, or a peripherally inserted central catheter, PICC, is usually preferred to a subclavian CVC, which has a higher risk of bleeding in pneumothorax, or a femoral CVC, which has a higher risk of infection. Ensure the patient is already connected to the monitor, ECG, pulse oximetry, and blood pressure. Pre-oxygenate the patient with bag and/or mask with 100% oxygen. Place the patient supine and in Trendelenburg position, bed tilted with the head down 15 to 20 degrees, to distend the internal jugular vein and prevent air embolism. Turn the patient's head slightly to the contralateral side to preliminarily expose the internal jugular vein but not cause overlap with the carotid artery. Prepare the equipment: antiseptic solution, large sterile drapes, towels, sterile gloves, ultrasound machine with a high frequency, for example, 5 to 10 MHz, linear array probe, sterile probe cover, ultrasound gel. Local anesthetic, for example, 1% lidocaine 5 ml, small anesthetic needle, for example, 25 to 27 gauge, about 3 cm long, large anesthetic/finder needle, 22 gauge, about 4 cm long. Introducer needle, for example, thin-walled, 18 or 16 gauge, with internally beveled hub, about 6 cm long. 3 and 5 ml syringes, use slip-tip syringes for the finder and introducer needles. Guidewire J-tipped, scalpel with 11-blade, dilator, central venous catheter, adult 15 cm for right side, 20 cm for left side, sterile gauze, for example, 4 by 4 inch, 10 by 10 cm, squares, sterile saline for flushing catheter ports, non-absorbable nylon or silk suture, for example, 3 to 0 or 4 to 0. Chlorhexidine patch, transparent occlusive dressing. Do a non-sterile ultrasound inspection, i.e., using an uncovered probe and non-sterile gel, and determine whether the vein is suitable for cannulation. Use a short axis, cross-sectional, view. Place sterile equipment on sterilely covered equipment trays and dress in sterile garb and use barrier protection. Syringes. Attach the introducer needle to a 10 ml syringe with sterile saline in it. Pre-flush all lines of the CVC with 3 to 5 ml of sterile saline and then close the ports with caps or syringes. Place a sterile cover over the ultrasound probe. Direct your assistant, non-sterile, to coat the probe tip pointing up, just outside the sterile field. Anesthetize the cannulation site. Swab a broad area of skin with antiseptic solution. Allow the antiseptic solution to dry for at least 1 minute. Place large sterile drapes, for example, a full-body drape, to establish a large sterile field. Use ultrasound guidance to measure the depth to the center of the jugular vein. Then, using an ultrasound guidance, insert procedural needle into the skin at a 45 degrees angle directed toward the midpoint of the probe. Inject anesthetic into the skin and soft tissues along path leading toward the vein. Insert the introducer needle with ultrasound visualization of the needle tip as you advance. When the needle pops through the wall to enter the lumen, accompanied by a flash of dark red blood in the barrel of the syringe. Hold the syringe motionless in this spot and visualize the tip of the needle at all times. Assess the blood return. Remove the syringe from the needle hub and briefly let blood flow out to confirm that the blood is venous, i.e., dark red and flowing, but not pulsatile. Then immediately cover the hub with your thumb to stop the blood flow and prevent air embolism. Carefully rotate the introducer needle such that the bevel of the needle now faces medially, i.e., toward the heart and away from the subclavian vein. Insert the J-curved end of the guide wire into the introducer needle, with the J-curve facing medially, i.e., in the same direction as the needle bevel. Advance the guide wire through the needle and into the vein. You may use ultrasound guidance, either short or long axis, to verify the guide wire entering the vein. Advance the wire 10 to 15 centimeters for a right-sided internal jugular insertion, 15 to 20 centimeters for a left-sided insertion, or until ectopic heartbeats occur. Withdraw from this point until ectopy stops. Securely hold the guide wire distal to the introducer needle and pull the needle from the skin. Then securely hold the guide wire at the skin surface and slide the needle down the remaining length of the guide wire to remove the needle. Using the scalpel, make a small stab incision, about 4 mm, into the skin insertion site, avoiding contact with the guide wire, to enlarge the site and allow it to accommodate the larger diameters of the tissue dilator and the catheter. Advance the tissue dilator over the guide wire. Grasp the guide wire at the skin and slide the dilator down the length of the wire to the skin. Use a corkscrew motion to stepwise insert the entire length of the dilator. Remove the dilator securely, holding the guide wire distal to the dilator and pull the dilator from the skin. Completely remove the dilator by sliding it down the remaining length of the guide wire. Maintain your grasp on the guide wire at the skin surface. Hold the guide wire fixed at the skin surface, thread the catheter tip over the distal end of the guide wire, and slide the catheter down to the skin surface. The distal end of the guide wire should now be protruding from the port hub. Advance the catheter into the vein. Then, in increments of several centimeters and using a corkscrew motion as necessary, stepwise advance the entire length of the internal jugular catheter. Use ultrasonography to verify intravenous placement of the catheter. Remove the guide wire. Withdraw the guide wire while holding the catheter securely in place at the skin surface. Flush each catheter port with saline. First, draw any air from the line and confirm venous blood flow into the hub. Then, using a 10 ml syringe or greater and non-excessive force, push 20 ml of saline into the line to clear it. Suture the skin to the mounting clip on the catheter. To prevent pulling on the insertion site, suture the catheter at a second site so that a curved or looped segment of catheter lies between the two sites. Disinfect the skin at the catheter insertion point by chlorhexidine impregnated disc. Apply a sterile occlusive dressing. Transparent membrane dressings are commonly used. Confirm placement of central line with chest X-ray.